Welcome to this concise video log on ART initiation considerations for an older patient with recently diagnosed HIV infection. This program is provided by Clinical Care Options and is supported by independent educational grants from Gilead Sciences, Merck Sharp and Dome Corp, and ViiV Healthcare. This vlog was recorded by Professor Josep Llibre. Before we begin, please note his disclosures on this slide. This vlog is part of a comprehensive educational program on caring for aging patients with HIV. You can gain CME, CE, or CPE credit for viewing these vlogs and download the slides by visiting our website, clinicaloptions.com.
Hello, I'm Dr. Josep Llibre from the University Hospital Germans Trias in Barcelona, Spain. I recently saw a patient who represents a challenging type of case that we can encounter, and we usually do, in our office, an older patient newly diagnosed with HIV infection. I'm going to go through some of the details of this patient's case and the relevant issues surrounding older patients with antiretroviral initiation. This is a 70-year Caucasian MSM recently diagnosed with HIV infection, no prior PrEP use. He's a non-smoker. He was not engaged in chemsex. He has hypertension and dyslipidemia, very common with his age. And his Framingham 5-year cardiovascular risk is obviously high, therefore 30%. He has no proteinuria and his kidney function is normal. And regarding all the baseline HIV profile, his CD4 cell count is 189 cells. His HIV plasma viral load is 79,000. The HIV genotype is wild type, so no transmitted drug resistance. The subtype is B. His body mass index is 24. And the complete blood count and the biochemistry and the hematology is normal, together with the metabolic panel. Regarding the hepatitis virus status, he is immune against hepatitis B and Hep C B is negative, and the HLA-B5701 is negative as well. He takes some medications. He's taking losartan for hypertension, simvastatin for dyslipidemia, tamsulosin for a benign prostatic enlargement, omeprazole for no given reason, gabapentin for unspecific back pain, and trazodone intermittently for insomnia. Antiretroviral treatment is especially important for older individuals, as you know, because they have a greater risk of serious non-AIDS complications and a potentially, but this is debatable, a potentially blunted immunologic response to antiretroviral treatment. The burden of HIV, of AIDS-related diseases is significantly higher among persons with HIV than in the general population, likely due to both traditional and non-HIV-related factors. Adverse drug effects from both antiretroviral treatment and concomitant drugs may occur more frequently, obviously due to the polypharmacy, and it's very important to take care to bone, kidney, metabolic health, cardiovascular health, cognitive, and liver diseases in older individuals with HIV that must be monitored closely. All of them obviously are associated to polypharmacy and what is known as the frailty syndrome, mainly what is called cardiac diseases that include ischemic coronary disease and hypertension, and everything regarding metabolism and nutrition, particularly dyslipidemia and diabetes. Hypertension and hypercholesterolemia are the most common comorbidities in these older patients. So these patients require a focused approach to prioritize all modifiable health-related problems. What do the guidelines say regarding antiretroviral treatment selection? Here you have 4 international antiretroviral treatment guidelines, and as you all know, we have a very high degree of agreement among them nowadays. They mainly recommend a regimen based on an integrase inhibitor, bictegravir, dolutegravir, or raltegravir, usually with 2 nucleoside reverse transcriptase inhibitors, usually any form of tenofovir plus FTC. For the first time, you know that the International Antiviral Society USA is not recommending dolutegravir plus abacavir plus 3TC as a first-line recommended regimen due to the exclusion of abacavir. It's the first time, the first one were the British, the BIBA guidelines, Now, the first international guideline that removes dolutegravir plus abacavir plus 3TC is this one, the IAS USA. In addition of these three drug combinations, it is also recommended a dual drug combination based on dolutegravir plus 3TC with some caveats. It's not a combination recommended in subjects with hepatitis B, as you know, in subjects with a low CD4 cell count below 200 cells in some guidelines, and we must have some caution in subjects with low adherence with these combinations. And in some guidelines as well, it's only recommended in people with viral load below 500,000. So this is the general recommendation of the guidelines, but as you know, they do not make any specific recommendation in all the patients or in subjects with a high cardiovascular risk. And in addition of all this, there's a strong recommendation to start antiretroviral treatment as soon as possible for all patients with a detectable viremia. So, no recommendation in older people. Is this right? Let's go to the information coming from randomized clinical trials. As you know, they always analyze the treatment response stratified by age. So we have information for dolutegravir 3TC. We have information for dolutegravir plus any form of tenofovir and 3TC or FTC. We have information for the co-formulation dolutegravir abacavir 3TC. And last but not least, we have as well information with bictegravir FTAF. They stratify usually the ages below 35, 35 to 50, or above 50. And we have information, as you can see, for 1, 2, or even 3 years. And there's no difference in antiviral efficacy regarding the age of the patients. So it's right, the guidelines are right in not making a specific recommendation for all the patients. If you accept an older patient of someone as someone with more than 50 years, there are no differences in biological efficacy. What do the cohorts say? This has been analyzed as well in cohorts. This is the information coming from RESPOND. RESPOND, as you know, is a prospective collaboration of cohorts, 17 cohorts. They have a very high number of treatment-naive subjects starting the first treatment, and they have analyzed 4 outcomes. A composite treatment outcome, which is composed, that's the first one in the graphic, composed of a viral load below 200 copies plus no regimen change plus no clinical progression, defined as no AIDS or death events. The second one is the strict biologic success. The third one is immunologic success. And the last one is clinical progression, as defined before with a new AIDS defining disease or death. As you can see in the table in the back, so in the bottom, there's no interaction between age and treatment success with no one of the 4 outcomes analyzed in the study. These are p-values, and there's no interaction between age and the success in any one of these 4 treatment outcomes. Our subject is a late presenter. His CD4 cell count is below 190. It's a late presenter. Late presentation, as you know, is still common in people with HIV and is particularly common in older people. Patients, as you can see, have been stratified regarding ages below 40, 40 to 50, 50 to 60, and beyond 60. And as you can see, the percentages of these 3 definitions of late presentation increase with age. So the frequencies of these definitions of late presentation of severe HIV disease at diagnosis increase paralleling the age of the patients. Late diagnosis or a more severe disease at diagnosis is so common in older people with HIV, basically due to the lack of awareness and a low index of suspicion among physicians. So physicians are usually not aware of the potential, of the possibility of having an undiagnosed HIV infection when patients go to the healthcare. And that's very important because some of them have had or have at that moment associated conditions with HIV that could facilitate the diagnosis, like bacterial pneumonia, herpes zoster, anemia, thrombocytopenia, lymphocytopenia. So it's very important to maintain a high degree of awareness regarding the potential presence of the HIV infection. Regarding the polypharmacy, older people living with HIV, obviously they have more comorbidities than younger ones, and they have an increased risk of clinically relevant drug-drug interactions driven primarily by non-antiretroviral medications. That's very important to be reminded in every consult. There's a specific recommendation in in any people with polypharmacy, not only in older people, but in any people with polypharmacy, to avoid boosters. So to avoid using of ritonavir or cobicistat that, as you all know, are CIP inducers. These are the list of the most common medications in that cohort that we were analyzing before in the veterans aging cohort study. The most frequent medications people are taking when they are older is antihypertensive, so lisinopril, amlodipine, and metoprolol, antilipemic agents like any statin, antidepressants, they are much common, and non-opioid analgesics and non-steroidal anti-inflammatory drugs. These are the most common medications, but older and younger people can take any medication for any given reason, and that's very important to be analyzed in every visit in our offices. Polypharmacy, it's not only drug-drug interactions. Usually when we talk about polypharmacy and many drugs in the same patient, the first thing that comes to our mind is drug-drug interactions, but that's not the only one. So it's a bigger issue of inappropriate prescribing. So there are many definitions. In this nice study run in people living with HIV in the US, they analyzed 112 people with more than 65 years. That's important because usually the analysis is done in people with more than 50. More than 50 does not include the biologic properties of aging or fragility. Aging and fragility really start at 65 to 70 years. The problem is that we have a limited number of people above 65 years, and usually just to increase the sample, they put the cut at 50 years, but they include a lot of people between 50 and 60, and these people usually don't have the biological properties of aging. So this analysis makes all the sense. People with more than 65 years, more than 100 people, and they define polypharmacy as 5 or more than 5 medications at the same time. They considered all the drugs that patients were taking, and usually most of the people met the definition of a polypharmacy. The median number of medications, overall drugs, was 12, including 9 non-HIV medications. They used 3 scores: the BIAS criteria, the STOP criteria, and the START criteria. That's very important because this criteria, for instance, the START criteria analyzes the treatments that should have been prescribed and were not prescribed in that patient. For instance, pneumococcal vaccination, influenza vaccination, vitamin C treatment, antihypertensive therapy, drugs that should have been prescribed and are not prescribed in that patient. The STOP criteria are drugs that should not be taken because there's no real indication for that treatment. That's very common in old people. They are receiving treatments that have no given medical reason, so they should be stopped. And the same happens with the BIAS criteria that analyzes the drugs that are not the gold standard treatments in that disease. You can see in the graphic the percentages of patients meeting at least one prescribing error. And you can see that on average, 50 to 79% of the patients meet the criteria for at least one prescribing error. This has a lot to do with not being only the HIV treaters, so not being only the responsible of the HIV part of the health of our patients, but being more like a primary care physician taking care of the overall health of the patient. And that's very important in all people. Another important thing is the weight gain. You know that there's a big debate nowadays with the weight gain. Has age anything to do with weight gain? Do we have to take any special care regarding the potential weight gain in our old patients? First of all, we're going to analyze a meta-analysis done by Paul Sachs with 8 randomized clinical trials analyzing initial treatment in more than 5,000 participants. And the strongest predictors, as you know, of weight gain were a low CD4 cell count, black rates, very important, and a high HIV RNA at baseline. But being younger, below 50, was associated with a small but significant greater weight gain versus older people. So all people are not at risk of greater weight gains. They stratified for people with more than 10% weight gain, and age. An older age was not associated with a higher gain. And the factors associated with a significant weight gain, more than 10% of the body weight, were again a low CD4 cell count, a high viral load, and being treated with bictegravir, dolutegravir, or TAF. So age was not identified as a risk factor. We have also information coming from cohorts again. Grace McCombs presented this analysis recently in the ID Week in October, and the risk of weight gain more than 3% of the total body weight 1 year after a switch coming from either TDF or abacavir to TAF, so a switch from TDF or abacavir to TAF. As you see the graphic, greater age was not identified as a factor associated with greater weight gain. So not particular interest with or relationship with weight gain with an advanced age. So what happened with our patient? Let's see the clinical evolution of the case. Our subject started the combination bictegravir FTAF, single pill once a day. We obviously advised diet and exercise. That's very important. Simvastatin was changed to atorvastatin 20 milligrams once daily. And at 4 weeks, we saw very good tolerability, and the plasma HIV RNA was below 20 copies per ml. That's fantastic. Remember that the baseline viral load was 79,000 copies. It's very common with integrase inhibitors to see a very fast viral decay. So it's not uncommon to see undetectability only with 4 weeks. CD4 cell count went up a bit, 204 cells. And at 6 months, we saw a good tolerability and treatment adherence. Viral load remained undetectable. The CD4 cell count is now 290 cells. We'll see in the future. And the LDL cholesterol, it's 89 milligrams. That looks fantastic, but remember that our patient has a very high cardiovascular risk, and the guidelines say that our treatment goal is below 70 milligrams. So we have to increase our efforts with this cholesterol. That's important because the analysis of people devoted to pharmacokinetics tells us that usually when we used boosters, we were forced to use atorvastatin in the lowest dose possible, 10 milligrams once daily. And when we went out of boosters, many times we remain with the lowest dose, and that's a mistake. So 20 milligrams seemed fine of atorvastatin, but we'll have to increase the dose to 40 milligrams to reach that goal of below 70 milligrams. The HDL cholesterol is 41 milligrams, which is fine. And the body mass index is now 26. It has increased 2 points. And you can see that the patient has entered the classification of overweight, above 25. It's only 6 months, but he's a treatment naive. And you know that in treatment naive patients, particularly in those with a low CD4 cell count, there's a return to health, and there's an initial increase in body weight. It's typically seen in people who have wasting. Our patient theoretically did not record a weight loss, did not have wasting, but in people with a low CD4 cell count, when they initiate the first antiretroviral treatment, they have a body weight increase, which has the interpretation of a return to health, also seen in people with a high baseline viral load. 3 drugs were deprescribed. Gabapentin is a drug that had no particular indication on our patient, so it was stopped. Trazodone, that was used as a drug for insomnia. It's not the best drug for insomnia, so it's stopped. And omeprazole had but no specific indication in our patient, and it's very commonly prescribed in older people. When they receive polypharmacy, someone prescribes omeprazole to protect the stomach. But as you know, omeprazole has specific indication and must be removed if there's no peptic ulcer disease or aspirin use. Our subject has no new comorbidities, so everything went well. And what are the take-homes that we can learn with this case analysis? Antiretroviral efficacy is not compromised in older patients, in older people living with HIV with any one of the currently recommended regimens. And that's a good news. No specific recommendations are made in guidelines regarding older people, but when you go to the sub-analysis, there's the same efficacy in people with advanced age. Obviously, there's a recommendation to prescribe drugs that are related with a lower risk of drug-drug interactions. Second, late presentation with a new HIV infection is still common, very common in old people. There's an awareness needed in older subjects with undiagnosed HIV disease, and watch out specifically any indicator disease of a potential HIV infection, especially in patients with sexual risk practices, even with advanced ages. Polypharmacy is the norm, and drug-drug interactions and inappropriate drug prescribing are common in older HIV-infected individuals. I would say that drug-drug interactions are decreasing, but they are still present, so they are still important. Antihypertensive drugs, antilipemic agents, antidepressants, non-opioid analgesics, and non-steroidal anti-inflammatory drugs, together with genitourinary agents, are the most commonly prescribed co-medications, as you have seen. And finally, age per se is not a risk factor for weight increase in HIV.